internationally, because not many centers in the world will have access immediately to MRI, and CT is very quick. CT can be done within a few seconds, essentially. And CT does not necessarily need for the child to lie down completely asleep or under sedation, as long as they can be there still for a few seconds. So it has a lot of added value also in terms of picking up fractures and things like that. Also, acute blood products. But the most important thing is trying to understand how in the urgent setting you can get the most out of your CT scans, particularly when you're dealing with situations where you do not know whether it is going to be normal, abnormal, safe to proceed to do a lumbar puncture, for instance, or something like that. So let me see if this makes a little bit of sense to you all. So we'll show some cases first, and then I want a little bit of interaction with you all, because it is a good, decent group. It is quite early out here in London, so I want you all to wake me up a little bit. So listen attentively. Thank you very much for sharing your videos, those of you who have kept your video on. And just to make this more meaningful, I think the chat option is also open. So I am just going to, first of all, say hello to all of you and see if you all can use the chat function, because I'll be asking you all some questions as we get along. And whilst you're still saying hello to me on the chat, if you can use that function, thank you, carry on. I am going to tell you that a normal CT scan has to be taken with a pinch of salt in an acutely unwell child. And a normal CT scan is going to be the commonest finding that you will get in your report. And perhaps having a very normal scan is the most useful, but the most difficult diagnosis to make. So let us look at the first case. This first case here on your screen. So far I have got 2 or 3 hellos. I would like all of you to interact and not just listen in, because this is not going to be just a PowerPoint didactic. This is going to be about interacting and giving some answers, asking some questions. And I do keep requesting people to keep their cameras on whenever possible when a virtual teaching session is going on in 2024. Nothing to hide. So here is a CT scan, and these are axial CT cuts, which are in a non-contrast. Scan was done in a child who presented with fever and a bit of encephalopathy, and the decision was to proceed with a lumbar puncture because a diagnosis of meningoencephalitis was being entertained by the clinical team. And CT scan was done to assess the safety of lumbar puncture. So how many of you think, based on the appearances given here, that this is proceed safe for lumbar puncture kind of situation? One step before that, let me tell you what a CT scan shows. So the hyperdense curvilinear structure outside is the skull on the axial imaging. You do see the cerebrospinal fluid, which is dark, and it should be a nice dark density. And this is within the lateral ventricles at this level. Out here, you see the temporal horns coming up, a bit of the basal cisterns, fourth ventricle out there on that particular slice. But you can achieve a CT non-contrast head scan in maybe maximum 7-8 slices to get most of your answers. But you can also do it in high resolution, which could be 1 millimeter or even 0.625 millimeters. I can show you a case of trauma after this to just understand acute CT a little more. But more importantly, you also get some information about the gray-white differentiation of the brain, and the cortex on a CT scan normally would appear a bit less gray or brighter or hyperdense compared to the white matter. And in many young children and neonates, it's even more difficult because the white matter has a lot of water. We saw a little bit of that in our part 1 of the talk, with MRI sequences looking different in adults and different in the very immature neonatal brains. But this is around a 3 or 4 or 5-year-old child, basically, who presented with encephalopathy, and a CT scan was done to assess the safety of lumbar puncture. Now, I think you all have this battle with your radiologists, and it's an international phenomenon where the radiologist says, we don't need to do a scan to assess safety of a lumbar puncture. You can't prognosticate, you can't even advise whether this is going to cone or not when you do a lumbar puncture. But having said all that, I believe this investigation happens still, and it has its role, it has its place in the sun, but the question is very important. So here the question is it safe to proceed to lumbar puncture? Which means you are deciding on whether this is a normal or an abnormal scan. So I want you all to use your chatting function there and tell me whether you think it is safe to proceed or not for a lumbar puncture. And whilst you're waiting and thinking, the child needs to be given a broad spectrum antibiotic cover. But before that, I'm sure as a good clinician, you want to get the CSF sample out. So, what do you proceed as? Your options are one, you think it is safe to proceed, you do a lumbar puncture. B, you don't know why the ventricles are looking a little bit prominent. Are they normal for a 3-year-old? But if the ventricles are prominent, then the gray white differentiation of the brain looks quite preserved. And yes, you have only done a thick slice CT scan, so you get only the axial view, Fahad, because it's not possible to reconstruct all of these scans into different planes unless you do a spiral CT with a 1 millimeter slice thickness. But when you put the question as safe to lumbar puncture, a fast CT scan is done, which could be 5 millimeters to anywhere at 10 millimeter slice thickness, because only a very specific question is being addressed. If your question was if there is any evidence of meningoencephalitis, then the radiologist would be tempted to do a contrast CT scan, and even then, there is no guarantee that you would get sagittal and coronal reformats. But in this case, I can tell you that the sagittal reformat would not have added any more at this point in time. So, yes, only with axial view, we have to decide whether this is safe to lumbar puncture. A question before that really is, what are you expecting in the scan that will tell you it is unsafe to do lumbar puncture? Let's answer that question. So the question is, what are the contraindications to LP per CT scan that you're trying to find out? Feel free to unmute yourselves and talk if you want. Okay, so Hussein is talking about cerebral edema and sulcal effacements. I don't know what that means, but probably it means sulcal effacement. I got that. Yeah. So if you have sulcal effacement, I can tell you that there is sulcal effacement. In this child, you don't see much in the way of sulcal spaces. You have gray-white differentiation preserved. Cerebral edema, you don't have. In this case, Abdullah. Hydrocephalus, you're looking at. But what is hydrocephalus? We look at hydrocephalus, we think big ventricles equals hydrocephalus, isn't it? So you have to decide if these ventricles are big or not. And then Hamad, you have given a very diplomatic answer by saying any signs of high intracranial pressure. So you're using imaging to evaluate pressure in the brain, and that's very, very difficult. And Dr. Sami says herniation, and there are no herniations going on here. Ballooning of the ventricles, you can see why this is difficult even for a radiologist, definitely for a clinician, because all these manifestations happen a little bit later. The reality of this story is that this child was given a normal report, and it was a wrong normal report. But for the wrong normal report, the child got the right test, which was a lumbar puncture and initiation of antibiotics. But the delays that this process took essentially meant that by the time the child has been transferred to a facility which can manage pediatric care, came to us, and these were the time differences. The case is stuck in the head. You can see it's been 10 years, and we still look at this case and learn from it. And what are the learnings? The learnings are those were signs of very early pressure rise within the ventricles. You don't have ballooning, you have prominence of the temporal horns, but this does not negate the need for a lumbar puncture. But if the radiologist had given a report, somebody needs to mute, I think. If the radiologist had given a report that this is raised intracranial pressure, then maybe the neurologist may not have proceeded to do the right test. Which also means that you're not really looking for soft, fine things. You're looking for big masses, big hydrocephalus, and other things. But don't forget that the management of idiopathic intracranial hypertension is serial lumbar punctures, and the management in adults of normal pressure hydrocephalus is also serial lumbar punctures. The fact of science is that the correlation between lumbar puncture predicting the safety based on a CT or an MR scan is zero. It does not. But you do a CT, we say yes because we hope that we pick up other abnormalities. The commonest finding on a CT scan for meningoencephalitis is a normal CT scan. The only thing that it will not pick up is, unless you give contrast, you will not pick up evidence of lots of meningoencephalitis and ventriculitis, but that does not change your diagnosis in any way. The child is encephalopathic, the child is crying, the child has had fever. By default, we are already thinking that there is an intracranial pressure rise in some way. But pressure and imaging so far, nobody has been able to manage. Even Boyle's law and Charles' law, going back to basic physics, cannot really, kind of provide a direct link between imaging findings and pressure. So keep that in mind, because that's a bit of a pitfall in the way we approach imaging. In this particular child, they do deteriorate a few hours later, and the scan shows the cardinal features of acute obstructive hydrocephalus. And here you have the bigger ballooned out ventricles, as some of you rightly said. And not only that, you have this change of density around the ventricles. A lot of people erroneously call this transependymal CSF seepage or leakage. Actually, what you have is interstitial edema within the substance of the brain. Because remember, the ventricular lining is intact. It doesn't have holes that you fill it up with water and it starts oozing CSF out. So it is interstitial edema that you get in this tissue. And that is important to remember, because even though okay, because even though you manage the hydrocephalus and try to drain the hydrocephalus, if you get to this point, you may not achieve complete normality after that, because there is already interstitial edema and microcirculation ischemia in the periventricular white matter. So we are trying to avoid this situation at all possible costs. In this unfortunate case, of course, between that time point and this time point, a lot must have happened and gone unnoticed, but a neurosurgeon would not have gone ahead and shunted these ventricles. That is also for sure a definite statement to make. So time is of the essence, but time is brain, we know that. But importantly, getting the context right and doing the right strategy for management is important. So I often talk to people about the CAT approach to scanning. The clinical question in your head has to be, what is the most important question that you need answering from the imaging? How old the child is, whether they need to be put to sleep in some format. And the test depends on the time of the day, the resources that you have, and the customer that you have, that is the child. Because, we can get away with a lot in children on a CT scan, but the moment we start talking acute MRI, these things come into discussion. If they're less than 3 months, you can get away with a feed and wrap scan. If they're less than 4 years, you can provide sedation. And then you might need GA in children who have a lot of developmental difficulties and they won't lie still. There is a lot of move, and it's correct that acute imaging should be moving to MR systems, because it gives you a lot more information about the timing, particularly in stroke or in acute tumor-like presentations, and the miss rate on a CT scan, even of subtle hemorrhage, can be quite high. particularly when you have not managed to do a CT scan within an allocated 6-hour period, for instance. So we talked about big ventricles and we talked about hydrocephalus. This is a case of a research volunteer, and you must be wondering, why is this person not showing us sagittal images? Mind you, most of the imaging still in the world is read on axial cuts. But yeah, it's always useful to look at sagittal scans, but I'm not trying to teach you how to pick up hydrocephalus here. I'm trying to teach you the limits of what you will action and the limits of what you can get out of imaging. So here is a healthy research volunteer. This is back to even 12 years ago. And you can see the time is out of hours, and it's a research volunteer. So they are healthy 12-year-old girl, and she's scanned by the radiographer out of hours. Clearly, there's no radiologist in the department after 5 o'clock. And in 2012, the situation was even worse. And you are called because you are the clinical person on call, whether you're a neurosurgeon or neurologist. And what do you do with these ventricles? So this is a normal child. The ventricles are big. And it is a true story that this 12-year-old, who would now be 24 years old, 12-year-old, completely well, excellent grades in school, no perinatal history of concern, just presented to get scanned, and these were her ventricles. And you can see that the ventricles are enlarged. Will you use the term hydrocephalus to design and kind of define this particular patient? And you have to think hard. The term hydrocephalus means nothing. It means water in the brain. So these Latin derived terms or Greek derived terms have actually lost a lot of significance when practically approaching the problem. There is ventriculomegaly, and there is a reduction of the white matter in the brain, particularly posteriorly, as you can see. And maybe this was the context of something like an arrested hydrocephalus in early life. But the brain has undergone a lot of rewiring, as you can see. And the child is really doing very well at school. It's a true story. And she wanted to become a lawyer and all that. Now, not that I say that lawyers need to have big ventricles to start with, but there was no concern. And of course, the options here are, should we recall, rescan? We looked at the sagittal, the ventricles were big, but there was no real features of raised pressure. You can see that there is no interstitial edema around these ventricles, and even though they are ballooned, they're not under pressure. And the important thing is, once you take a balloon and you fill it with water and you enlarge it, or you blow the balloon with air and it deflates, it will never go back to its original pristine state. They lose their compliance. So this would have been a ventriculomegaly, which would be antenatal in this child's life, except that it did not bother her, luckily, and she never came back for any further workup or anything. If you allow the surgeons near such patients, they want to make things look better. And if you put a drain in there, you will pick up zero or even negative pressure within these ventricles. And the problem with draining and overdraining ventricles, as per the Monroe-Kelly doctrine that you might remember, you've got the brain, the CSF, and the box phenomenon, which are in equilibrium with each other. You run the risk of creating subdural effusions when you start overdraining these ventricles for no good reason. So treat the symptomatic child, but you will come across these nuances, and then you have to really think hard as to what should be done next. HET CT, common test done worldwide, and the non-controversial indications for a HET CT are trauma, acute unexplained encephalopathy, and particularly when you have lumps or bone disease or bad sinusitis and you're trying to assess the complications from these particular processes. The controversial indications, however, are scanning for headache, the pre-lumbar puncture case that we just saw, and a single uncomplicated seizure. So those have to be avoided at all costs. So here's a case, and this is a case from some years ago, a sad case. So once again, a plain CT done for headaches, and this was a child that went to 2 hospitals before they eventually came back to our hospital. What is going on here? And I can tell you this child is 4 years of age, not very different from the previous age group that we just saw. So back to you for questioning. This is a child who's 4 years of age with headaches. We've done a CT scan, and we do a CT scan because it's easily available, but we run the risk of missing findings, and it was missed in 2 hospitals. I'm showing you very select images here to get your eye into it. And this is a PowerPoint platform today because these are historic cases. In fact, they don't even exist on our hospital archives anymore, but seriously, seriously important cases. And the clue here is that you do not see what you cannot see. So, what is it that you cannot see? I'm going to put that in the chat. What is it that you cannot see? And this is going back to very basic anatomy. We like keeping it basic on this platform. Uh, to start with, this was your initiation into CT today. You've got the left and the right cerebral hemisphere, the white matter appearing dark, the cortex appearing dense, and that's because it has got a lot of packed cell neurons. So the density on CT scan will be relatively high compared to the white matter, and the density of CSF will be even lower compared to the white matter. So 3 shades of gray, if you think about it. Um, you can't see the vessels. You're not expecting to see the vessels. You can see a bit of choroid plexus. You've got the basal cistern here. You've got the left, right lateral ventricle, the aqueduct. And yes, I think Dr. Farah Nasir and Dr. Ali Al Othaibi have got it right. You don't see a fourth ventricle, and I'm trying hard to show you a fourth ventricle on the final picture here. And you don't see a fourth ventricle because there is something filling the fourth ventricle, which is relatively hyperdense as well. So yes, and it's a pity that this child was referred by gastroenterology with headaches and query. There was a question mark on the form, posterior fossa mass, and in spite of that, it was missed. And they were referred for a reflux study because they thought that the gastrointestinal problems need to be evaluated. Then they were sent back to another hospital, more headaches, scan reviewed again. It's very hard to see what is not visible. And here, the fourth ventricle is not visible. The sad reality is by the time they came to our hospital a few weeks later, they had already bled in that tumor within the fourth ventricle. And once again, you are seeing the change of ventricular morphology once you have very significant obstruction to the CSF outflow. So here we have large ventricles, interstitial edema around the ventricles, and a hemorrhagic tumor. And I can tell you that this eventually turned out to be a medulloblastoma that had bled. And the child did not do too well. Unfortunately, I guess we could have totally resected the tumor at that particular point in time, and the outcomes would have been better. The moment you have hydrocephalus step in with a tumor presentation, the outcomes cognitively, even if by survival are better, cognitively, they are not. So that is about ventricles, a little bit about axial imaging, gray white differentiation. And remember, you will not see a lot of sulcal spaces in children easily unless they are atrophic. And this particularly becomes even more difficult as they grow older because the brain tries to fill up the spaces given to it. So you can't easily always use that in terms of differentiating race pressure from not race pressure. One of the main questions that you will encounter in neonates as well as older children is the problem of venous sinus thrombosis. And CT has a role, but there are other modalities as well. But this is the more common scenario in the very acute setting. And you have to make a difference by either diagnosing or picking it up or even speaking to your radiologist and asking them the right questions. The problems and the pitfalls with CT in that respect are as follows. Now, first of all, I will show you the non-contrast situation of a 3-week-old and the same at 6 weeks. So 3 weeks, you see hyperdensity within the venous sinuses, that is the straight and the torcular out there. And the hyperdensity is expected from physiological polycythemia. So, physiological polycythemia, which these kids have at that age, and also the fact that they have hemoglobin F at that age, will give you a relatively high density. But remember, this is not with contrast, okay? And the other thing is that the torcula out there, the superior sagittal sinus confluence with it, it is concave out in its margins. If this was convex and swollen, that means it had a clot in it. Unless you get that configuration, you should not be worried in the very young. As they mature, the density of that does come down quite drastically. By 3 months or so, it's all normalized. But and CT can help you measure these densities, except that I'm not going to teach you how to use these values today. But I'm just going to give you an overview of what the physiological appearances are at that particular age group. Compare that with this situation where you have large, dilated dural venous sinuses, internal cerebral veins, even your cortical veins that you see are quite chunky. So, what do you think might be going on here? Is this a situation of an extreme pan venous sinus thrombosis or venous thrombosis in the brain, or is this something else? And whilst you are still thinking, this was also labeled initially as physiological, but the problem we have is that these are indeed thrombosed. And as time progresses, we start seeing very convex, large, expanded, rounded sinuses. I was trying to show you on the first case the concave margins, and here you have the convex margin. So, yes, Dr. Abdullah Joma is right, cerebral sinovenous thrombosis. And it's not just the dural venous sinuses. In fact, all the veins here are at significant risk of whatever is going on. And this was a term neonate who was unexpectedly hypotonic at birth with poor respiratory effort, requiring resuscitation, and then developed seizures at 12 hours of life. And initial CT was done on day 2 of life, which also not only does it show the venous sinuses like that, actually, there's a picture of a diffuse brain swelling because you have lost the sulcal fold pattern of the brain because in neonates you have a lot more space around the head and you're not seeing any pattern of the cortical and gyral folds. So yeah, hyperdensity with expansion, and then the CT is done at day 9. And the reason why nothing is done, because in neonates, and you can teach me better on this, in neonates with venous sinus thrombosis, unless and until they have an infarction in the brain or they have a large hemorrhagic clot associated with it, the treatment lies really with managing the sepsis, managing the hydration status of the child. But in this case, of course, the seizures continued, and the fact is that the child had seizures. So when they have seizures, there should be a low threshold to treat. This child was not treated, and they remained refractory to any other form of medical treatment. And whilst we can see that the cerebral swelling has resolved on day 9, there is increased density of the thrombus. And then what we do is an MRI. So we hope that MRI is the messiah. It will be the ultimate diagnostic tool, but it is not. In fact, MRI is filled with even more pitfalls. So generally, what you would see in MRI is this kind of dark signal on the T2, like you see in these blood vessels, you see in the arteries, and that is called flow void, which means that there is flow and it's a flow related signal. But if you have deoxyhemoglobin, because this hemoglobin product in there, which is thrombosed, is maturing away, deoxyhemoglobin can actually appear quite dark on the MRI scans, and that doesn't help you because you think it is flowing, but actually it is thrombosed. And then you also look at the MR venogram, and there is lack of flow in multiple areas. But I can tell you the MR venogram is a pretty difficult investigation to interpret in a neonate. You can use ultrasound, you can use CT, and the most important form of CT would be a plain non-contrast CT, because the moment you give contrast, it may pick up some enhancement. Clots can enhance depending on how long they have been there. And if you pick up enhancement in the clot, then you're really, really confused. And the effect of T1, this is a T1 weighted sequence. This is the effect of T1 shortening within the thrombus sagittal. So you can see the different MRI signals, and it's useful to look at not just one sequence, but different sequences on the MRI, even before you do an MR venogram to confirm this. Unfortunately, this child died because the seizures were uncontrolled and they finally had a respiratory arrest. But we did everything we could in terms of helping with the imaging and conforming to them. But you begin to see a lot of pitfalls of the imaging. And this was the day 15 repeat scan. And this time you can see that the clot is actually enhancing in there. At least most of it is enhancing. So it becomes even more difficult. So venous sinus thrombosis is hard and it's confusing and scary, frankly, to anybody. And till date, I do worry about the patients when I look at appearances like these. Now, here, what you have is actually quite a swollen brain. Here, you've lost your gray white differentiation. If you think about the first two cases we saw, in spite of the tumor, in spite of the infection, you had preserved gray white differentiation. And here you have totally lost the gray white differentiation, and you have these deep veins, and the choroid plexus also quite hyperdense. These are the internal cerebral veins, and this is deep venous thrombosis, which can be very life threatening. And if nothing, it can cause a lot of hemorrhagic injury in the thalami. So, this is internal cerebral vein thrombosis. Let's compare that with this situation. What do you think might be going on here? So, once again, a neonate, CT scan. You've got variable densities, very large sinus here, something quite large sitting in the middle, lots of dilated blood vessels associated with it. It's hard to say from these axials what is artery, what is vein. But look at the state of the brain around. It is very atrophic looking brain. You don't have much brain tissue. Um, but a CT scan was done because it was the urgent test to do at that point in time. They wanted to confirm the diagnosis. And what is the diagnosis here? And I can tell you that the child was in congestive cardiac failure. And the reason to do a CT scan was to check what's going on in the head. No other reason. It's not always easy to do an MRI scan in children like these who present with congestive cardiac failure. They have a lot of attachments and they may not even be MRI compatible. And yes, Dr. Sami is correct. This is a vein of Galen aneurysmal malformation situation with a melting brain syndrome. Untreated vein of Galen malformation leads to a melting brain. Have you heard of the term melting brain? So you have to think about why such a rapid arteriovenous shunting that is happening in the brain can lead to melt of the brain. So it is not hydrocephalus only that is happening here. There's actually a significant and rapid atrophy of the brain tissue at the same time. So read a little bit about vein of Galen aneurysmal malformations and the fact as to why you need to treat it urgently. A, you need to relieve the pressure of the AV shunting that also makes the congestive cardiac failure worse. That is the main reason. But the second thing is to prevent any further damage to the brain and to prevent this thing called the melting brain syndrome. And this was one of our cases, which was a very rapid and aggressive form of that phenomenon being shown. So yes, there is a clot. You can see there is a clot being formed. There is venous sinus thrombosis, so to say, but there's a lot more going on in this context of a vein of Galen aneurysmal malformation. I did talk to you a little bit about the pitfalls of MR imaging, and when you are in a neonatal situation, and I've told you, and I'm going to completely disappoint you by saying that in neonates you can get prominently large venous sinuses and you can get a signal like this on particular sequences, which is patchy, heterogeneous, and at different time points it looks different. These are flow-related changes. This is flow-related phenomena, and it is the turbulent flow of the blood within these slightly dilated channels that causes these flow-related artifacts. So This is a case which a particular neuroradiologist called venous sinus thrombosis based on basic principles. The other one did not, and there was a contest between the two of them. Which test would you use to resolve the problem? And whilst you are going to answer that on chat, I can tell you that this child does have some abnormality within their deep gray structures. They had a hypoxic ischemic injury situation going on. So that was definitely abnormal in that particular case. So let us know um, what you think you would do to resolve the fight between two neuroradiologists, pretty eminent, one of them calling it thrombosed, one of them calling it not thrombosed. And DSA, Dr. Sami said, digital subtraction angiogram is a very big undertaking. Any simpler test before that? Anything you could do on the bedside? And that is very important to remember because in neonates, you have a lot of potential with this modality of imaging. The answer is yes, ultrasound. And I think Dr. Sami gave the final kind of proof of life test with DSA. But one step before that would be to do an ultrasound scan. Because with an ultrasound scan, not only can you assess the flow using Doppler, but you can also look at compressibility of the sagittal sinus and some of the other sinuses through the amazing acoustic window that you have with open fontanelles, as well as from the sides where you can interrogate the lateral venous sinuses. So really useful test. If you're stuck, please do recommend. In fact, nowadays, if I'm doing a CT or MR in the acute setting, I advise the clinicians to also get a cranial ultrasound done because you can press on the veins to see if they're compressing and you're not really affected by flow related changes on ultrasound. And the Doppler will also help you pick up flow when required. One of the things, this is not strictly in your remit, but if you keep pushing for scans on children and CT scans, the radiologists sometimes say, oh, let's keep the radiation dose low. Let's do a quick scan. And this is that situation where what has happened here is everything looks abnormal and swollen and you've lost your gray-white differentiation. And that is because the scan was done with a very, very low current. MA is how you provide the current and the amperage, and the kilovoltage is the electricity supply that is going through the scanner, so to say. So if you give very little energy, then you will have very low energy radiation going to the brain, and that low energy and weak radiation will not be able to create diagnostic images. So you need penetrability for good quality images. And penetrability comes from the strength of the radiation that's what you're inflecting into the brain. Remember, everyone in the world talks about let's reduce the radiation dose, which is fine and very good. But modern day CT scanners, the radiation dose is not a significant penalty if you were to look at the risk benefit analysis of that. And you can get away with a 2 millisievert kind of radiation, which is significantly less than a transatlantic flight that you would take to go and party in the US. So here, the problem is not of what the pathology is. This is a sub-diagnostic scan. It's a waste of time, effort, radiation, energy, everything, because this is some center trying to do a very low dose CT, and that is not useful. So a test is useful when it is really useful. But you can get situations like this, and here there wasn't a problem with the dose, but this is a very tight brain. And it is so tight that you have effaced the ventricles, you have lost the gray-white differentiation. The patient was of Turkish origin, and you're beginning to see what looks like maybe some changes within the dentate nuclei around the cerebellum. You can see the dentate nuclei pretty much there. So question is, what are we doing here? This is a child. I can tell you the story again many years ago. The story is the child's scan was lying on a pile waiting to be reported. They had been referred by another hospital only for developmental delay. So this was not an acute scan. So you can see how much a child can get away with. Not only do you have this what looks like swelling or no space left in the head, you have squished ventricles, And if I were to answer your question, is there raised intracranial pressure? Of course, it looks raised intracranial pressure, except that it was not. Also, on closer inspection, we begin to see a little bit of periventricular calcification. So you have to raise the possibility of a metabolic disorder here. You don't need to get the diagnosis right. And in fact, I can tell you it's been at least 13 years of this case, and we still don't know the diagnosis in this particular child. So you don't always get the diagnosis. This was the child has gone back to Turkey, but it was a cold case lying for a cold report. But we had to call the hospital, and they said we thought the child was well, and we sent them back home, got the CT scan, and we sent it to your hospital to get it reported. Essentially, that's what happened. So always, I mean, you do it well as clinicians. You look at the child and then the scan, but I think you should force your radiologists to look at the child if possible, or at least tell them a good story to go with it. One of the things that in your practice you will really face a lot of is increasing head circumference. And children, when they increase their head circumference in the infant period, at least around 4 months, 5 months, 6 months, it's a very rapid increase and it's very scary at times. So scary that you want to get some investigation done. You can get a CT, you can get an MR, you can get an ultrasound, and you encounter a situation like this. So another set of CT images here, and this is a referral for rapidly increasing head circumference in this particular child. And you can see that here there's a lot more space around the head, at least anteriorly. You've got prominent ventricles, and then you're beginning to wonder if what is this? What are these dark bits? So can you tell me on chat, what do you think these are? Are these small chronic subdural effusions, or they are normal, or there is something else going on here? And that little structure you see is a vein, basically. It's a bridging vein that would be going from the surface of the brain to the dura. So let's see what you all can say. Your options are normal, that's one thing, or you can give an option of subdurals, or epidurals. What do you think might be going on here in terms of these dark areas in the front? And the child has a big head, so there is macrocrania going on. Dr. Abdulaziz is perfectly right. I will break that best term down a little bit, though, because this is a condition which typically presents from 4 months to up to 18 months of the rapidly increasing head circumference. And when you look at the family, you get macrocrania in the family as well. So a lot of terms have been given to this particular entity, including what Dr. Abdulaziz just mentioned as benign enlargement of subarachnoid spaces. But how many of you will be happy to leave it as benign enlargement of subarachnoid spaces and do nothing more about it? That is the test of confidence, not about labeling it. Question for clinicians, are you happy to leave it alone, or do you want more? So the question is, do you want more? Generally, the children are, well, not generally, always, the children are neurologically well. The only problem they might have is supporting their head at 4 or 5 months. When you begin to learn how to support your head, it might be tricky because the head is so big that they might just wobble it around a bit. And it is indeed a problem with these big heads to keep them steady. And the head circumference generally crosses centiles and goes up to 95 to up to 99 centiles sometimes. And it's quite scary for the general practitioner. So yes, reassuring, then no worries. I agree, but it's quite a hard call. And many times we are then asked to do an MRI scan on top of that. So anyway, when some entity has so many different names, it should probably have just one name, and that is normal, which I have not mentioned here. But normal appearances are hard to call, as I said to you. This child was rescanned for some reason, too much CT going on in the UK, right? At 19 months, and you can see that the head grows to fill up that space which was afforded to it. So these are subarachnoid spaces. There is no collection. If there was a collection sitting here, you would have lost the contours of the brain. So these are subarachnoid spaces. And with time, the subarachnoid spaces fill up. They still have a big head, And in fact, if you took a family picture, and you should look at the family anyways you do, uh, there will be a bit of a macrocrania running in the family in these situations. So that is the outcome of enlarged subarachnoid spaces. Benign is a term that is used. Are they really always benign? It's hard to tell. You can get small subdural hemorrhages and collections within these. And the current thinking is that the spaces becoming prominent is something to do with impaired venous drainage in early life. It could be fetal life as well, but it is not a fully substantiated theory. Compared to that, when you have a situation like this, and this will be my last case today, I think, before I want to leave you with this thought. It is a silent pandemic going on in the world, but here you can't call it benign enlargement of subarachnoid spaces. You can see that there is collections which are effacing the sulcal folds of the brain sitting on the surface out here, bilateral. The density is a bit intermediate, and there are some hyperdense areas more posteriorly. What is the scenario that we are talking about here? So you might get only this in the context of a child who is encephalopathic or not. They may not always be encephalopathic, but I'm expecting the kid to at least have some seizures here because they have a lot of mass effect on the brain. And you have bilateral mixed density subdural effusions in multiple compartments, at least in the front and in the back. What do you think might be the first diagnosis in a child who is under 2 years of age? So, child under two, unexplained subdurals. What are you thinking about as the most likely possibilities? You're going to exclude infection. You're going to exclude a coagulation disturbance. And then you have to think about, as Dr. Abdulaziz and Dr. Sami have been nicely interacting with me, thank you very much, gentlemen. You have to really, really think about abusive head trauma. The commonest cause of unexplained subdural hemorrhages in and under two, even in the absence of any other sign, would be abusive trauma by a mile. Dr. Ibnouf is right. I mean, there are some mimics to this particular entity. You have to probably think about excluding metabolic entities like glutaric aciduria. And in glutaric aciduria, what you typically get is underdevelopment of the frontal temporal lobes, open operculum. In the crisis situation, you can get density and signal changes within the basal ganglia structures. It is rare. It is much, much rare compared to the context of abuse. And abuse from a multiple aggressive shaking is what we are talking about here. There are certain countries in the world where it is hard to make this diagnosis, not just medically, but also socially, as to what do you do after that. Parents get very angry, relatives start attacking the hospital. Those situations, of course, we can't discuss in this CT-based meeting today, but I'm sure you're aware of as clinicians as to it's a very hard diagnosis in some countries and some cultures to make. And taking away the child from their parents is a very big deal. But if you do encounter this situation, at least the possibility should be raised, and then we have done our little to prevent further abuse of children in these families. These children, of course, go on to have an MRI scan, and this child had an MRI scan a few days later. And you can see that these are very well organized collections on the two sides. There are some septations within these collections, and these septations refer to as neomembranes within these large effusions. You can see there are some maturing blood products still sitting on the surface of the brain out there, also in the ventricle. So there has been a hemorrhage at some point, but they look like quite remote, well established. So it's very hard to age the possible insult when you have appearances like this. And incidentally, the child also had a fracture on the CT scan. This is the other utility. We talked about bony injury, much, much better on a CT scan. They had an undisplaced fracture, no scalp swelling. So you have context of possible shaking injury here, along with a fracture, and therefore that makes it a shaken impact type of abusive head trauma, which is the commonest kind of combination that you would encounter in practice. I don't know, and you can share with me your experience in Saudi Arabia as to how you deal with a situation like this. But it is not easy, particularly in countries where I have asked this question, like in India or Pakistan and Bangladesh, because there is a lot of stigma attached to the diagnosis, and there is no facility for these children to be taken away into a safe environment as well. So that's where we are stuck with these particular things. Shaken and impact situation is what we're dealing with. Final thought is on this slide here is of mixed density. So when you have mixed density collections in the context of abusive head trauma, it does not mean that there has been more than one insult. Generally, as the shaking happens, there is injury to the small bridging veins. So there is venous injury. That means there is bleeding. And the bleeding typically happens in the subdural kind of area because the subdural space is the potential space only. There is also injury to the arachnoid membrane, which is a thin, friable meningeal lining around the brain, and that leads to the leak of the CSF or the cerebrospinal fluid. So you have mixture of CSF leaking from the arachnoid tears, venous blood mixing and coming from the veins, and that is what gives you the mixed density on CT and the mixed intensity on MR. And very typically, you have these as mixed densities. It does not mean that you have an acute or chronic and multiple time insults. In fact, it is usually the one moment in time when the parent or the carer loses their temper on a child who doesn't stop crying, and they shake the child in the hope that they will stop crying. They do stop crying, but they also go very still, and that is exactly what's happening inside the head. You may or may not encounter the additional aspects of hypoxic ischemic injury in these brains. So I'm going to just pause because somebody needs to mute. And let me see what else do I have. That's it. We're going to park here today. I wanted to show you a lot of CT scans in the context of trauma, in the context of meningoencephalitis, as well as in the context of tumor presentations gone wrong. Any questions, let me know.
Thank you very much, Dr. Kish. I just have one question regarding